Thank you so much. Are there any other questions from the audience that we could possibly field now? Yes, sir.
My name is Alistair Matheson from NATO, National Association of County City Health Officials. Earlier in responding to a question, you implied that physicians might connect to the NHIN through another HIE or something like that. Presumably those HIEs will also have some sort of data use agreement type thing. Are there any mechanisms in place to reconcile when there's a difference between DURSA and maybe an HIE that has its own internal policies?
Yeah, I would say that what we attempted to do is anticipate that when the DURSA was developed, which is part of the reason that we do have the list of flowdowns that I showed to you. Now, to the extent that an HIE had a provision in their data sharing agreement that was contradictory, directly in conflict with what's in the DURSA, then they would need to modify that in order to become a participant. I haven't seen that happen yet, and I would be surprised if that were the case. But I'll give you a great example of how we tried to anticipate exactly that in the DURSA, and that's the label for this issue is the autonomy principle. And here's what it means. In the context of drafting the DURSA, we learned, since we had folks at the table from all across the country and representing many different types of private sector organizations, we learned that in some HIEs, they have a rule that only physicians are given the authority to request a record, to request a data result. In other exchanges, nurses are given that authority, and others. In other words, a practice in some communities, a practice can designate here are the folks within my organization who have permission to access, let's say it's a local health exchange, and here's the role that I'm assigning to that person. And once you do that, then there are certain rights that the system assigns to that role. I think we all understand that. Well, so we learned that there was a pretty significant discrepancy across HIEs, and the most glaring one was around who can initiate a request, physicians only or physicians plus others. So we talked about that at some length, and what we ended up doing was saying, well, we can't reconcile. There is no reconciliation. Folks have different rules for reasons. They have the rule that makes sense in their community, and we are not going to preempt that because that's really up to them to decide what's right for their community, and there will be differences. So what the DURSA says is that participants are free to administer their policies and procedures that they have created, and that's the so-called autonomy principle. Now, so what that means, what that does mean, that if an HIE has a policy that only physicians are permitted to initiate queries, requests for records, if a query is initiated by another HIE, by someone whose digital credentials are RN credentials, for example, then the physician-only HIE is not obligated to recognize that request. They're not obligated to. It would not be permitted within their organization, and we are not going to ask them to violate their policies and procedures that they've adopted through the DURSA. They could if they wanted to. They're free to, but they're not required to. And so that's one very granular example of how we attempted to recognize that there are differences, that there will be conflicts, and rather than, we intentionally did not write the DURSA to create a conflict with a local HIE, but rather to try to respect the decision, whether it's legal, cultural, whatever you want to call it, and frankly, it's probably a combination of all of those. We want to respect those decisions and recognize that they have them for a reason, so that we don't create the type of collision that your question alluded to. It's a great question, though.
And Steve, I might add, maybe on a kind of higher level, The mechanism for addressing that, those conflicts at the NHIN level, is the coordinating committee. And so I would assume that any participant or any entity who wants to be a participant would likely raise the issue with the coordinating committee if there is a suggestion or a recommendation or a request for a change for whatever reason. The coordinating committee at this point would be the entity that decides if indeed it will or will not address that in any kind of amendment or change to the DURSA. Again, it's probably up to that entity, the Health Information Exchange. And I should point out that not only health information exchanges might ultimately be participating in the NHIN. I mean, there might be other types of organizations that participate on behalf of patients or on behalf of clinician users. But at this point anyway, the mechanism that's in place is the coordinating committee for addressing any reconciliation of issues.
Missy, you have a question.
Hi, I'm Missy Hyatt with Deloitte. I had a question about the discussion of trust agreements around NHIN Direct and how the DURSA might play or fit in or might not fit in.
Who is most suitable to answer that question?
Well, I'll start.
You start.
I think that NHIN Direct is.
Should I repeat the question just in case?
Sure. The question was how does the current activities that are being undertaken through NHIN Direct relate to the DURSA, essentially, and vice versa. I think that the answer is that we are still evaluating that. The DURSA is a tool that, if you think about NHIN Direct as a very creative and innovative way to develop a set of specifications around a different exchange framework, and it's it's happening as we speak, and I understand that their trajectory is October of 2010, I believe. That so where they will emerge, I don't know that any of us know that at this point. But certainly, having talked with those who are involved in direct activities, I think there's a recognition that whatever model or models may emerge from the direct activity, it still fits into the trust framework that we talked about earlier, and that that really does transcend architecture and models. Now, the DURSA was not written. It was written as a multi-party exchange agreement. It may or may not have components that are relevant to a different type of exchange framework. I honestly don't think we know enough yet about the different exchange frameworks to definitively answer that question.
I think that was a great answer, Steve. And when I can't answer a question directly, I tend to just try to answer it abstractly. And I think a lot about the NHIN being a set of services, specifications, and policies, and NHIN Direct being a project within that atmosphere, and NHIN Exchange being a particular instantiation of exchange within that environment. Abstractly, any set of services could be identified by the coordinating committee or the governance bodies in the abstract, and it would be upon the decision process of that particular exchange and the participants of that exchange to determine whether or not that service set belonged, and if their mechanisms were in place, and that it was a benefit to their exchange participants to have it in there. And I think what Steve was saying is we're in that process of looking at this and saying, is it of benefit to VA, DOD, Kaiser Permanente, and others to have the processes that they use to include NHIN Direct eventually? How does that fall under the governance of the NHIN Exchange? And that takes time. There's nothing that we can rush through here, and we have to just patiently think through these things. Indirectly, I think that relates to a lot of the questions that we've got. So I think I'll just go back to these questions,
Sure.
which unpack those concepts a little more and see where we get. And I love the Q&A process because it's really very, very interesting. So we put together this event to talk about multi-party agreements. And one of the questions, to be paraphrased, is do you always have to have agreements to exchange health information exchange? Is there anybody or any exchange model that would be permitted? We presume some folks are exchanging data today without trust agreements in place. And is that something that we expect the governance model to begin to address, the policies of ONC? Or do you foresee that it will always be possible to exchange data via fax in the current universe?
Well, certainly, sure. I mean,
Yeah.
today, exchange lowercase. That certainly is happening today, and I think it will continue to happen. And in fact, one of the early iterations of the trust framework, we were looking at different exchange models, and one of the models was one provider to another, things that happen all the time today, where the parties each know each other. They may have already had, envision, if you will, a medical and a surgical oncologist, cancer physicians, or a primary care physician and a specialist, where they probably have an existing professional relationship, and they're exchanging data as we speak, probably through fax, but perhaps not. Essentially, the way I would say that what exists there is a social contract. The parties know each other. There are mutual expectations about how the other will act. They know who they are. They know that it's that person's fax number. And if you go back to the, and I won't do this physically, but if you go back to the trust framework pie chart, you can really go through and tick off every one of those components and find that they really do exist in that arrangement. And now sometimes you have providers who exchange information for the first time. So there is no pre-existing relationship. But usually there's some type of activity that occurs to create a foundational level of trust to allow that. So to answer the question, do you need a DURSA or even a written agreement for every type of exchange? No, of course not. That happens today. But it is, I think increasingly we are seeing, and they're not always called, data sharing agreements. Very often they're called, they may be called service contracts or purchase agreements. But if a medical practice is engaged with one of the clinical laboratories and they're doing electronic reporting, there will be some writing somewhere that includes some application of legal responsibility. And so I think that there'll continue to be room for both written agreements and social contracts within the healthcare delivery system. Just my opinion.
I think, again, with the Q&A model, we have from one extreme individuals exchanging data and asking questions about do I need to codify how I comply with the trust framework that we've defined. And on the other extreme, we have some questions from folks that describe themselves as state AHIEs that are not yet ready to determine if they are going to become participants in the NHIN. Would you recommend that these state HIEs that are still undecided, don't know if it's right for them, utilize the DURSA for its own intrastate multi-party agreement development? Is that a good starting point? Is that a good at the state level versus, is there some inherent difference between what we needed to do at the network level for the federal, at the federal level versus at the state level?
Yeah.